So good morning, everyone. I just wanted to introduce Dr. Folasade, who we are very privileged to have join us today. She's an assistant professor of medicine at the Vatche and Tamar Manoukian Division of Digestive Diseases at the University of California, LA. And she's also a staff physician of Gastroenterology in the Greater Los Angeles VA healthcare system. She graduated from Yale University with a degree in molecular, cellular, and developmental biology, and then attended the University of Cambridge in the UK, where she obtained a master's in epidemiology. She subsequently attended Harvard Medical School and then trained in internal medicine at Mass Gen before attending the UCLA Specialty Training and Advanced Research Program. There she did a GI fellowship as well as a PhD in health policy and management from the UCLA Fielding School of Public Health. At this time, she's the director of the May Health Services Research Lab at UCLA and director of quality improvement in gastroenterology for UCLA Health. Her health services research focuses on cancer prevention and control and health equity with projects in the UCLA Health in federally qualified health centers, as well as the VA. She's really passionate about improving colorectal cancer outcomes, especially in underserved populations where screening rates are the lowest. So today, we are really privileged to learn about some of this work as she talks to us about addressing racial and ethnic disparities in colorectal cancer. So Dr. May, thank you again so much for joining us. We're really excited to hear your talk today.
Good morning from Los Angeles. I'm honored to be here. Thank you so much for having me. Hopefully you can see my slides that I just started sharing.
Yes, you can see them. Yes.
Perfect. Thank you for that beautiful introduction. As mentioned, my name is Folasade. I'm a health services and health equity researcher. I work at UCLA and also in the VA. And I run a lab that focuses on health services research, specifically in cancer prevention control. And I'd say most of our projects are in GI cancers, and about 50% of our projects are related to health equity. And the other hat that I wear is I'm one of the quality directors for our UCLA health system, specifically focusing on gastrointestinal health and quality improvement around GI disease. It's an honor to be here today. I'm grateful for the opportunity to speak with you. The title of this specific talk is Addressing Racial and Ethnic Disparities in Colorectal Cancer. I have intentionally left some time at the end for questions. However, if there are questions during the talk, please interrupt. I'd love to take those actively as they come up. So my hope today is to provide an overview of colorectal cancer impact, especially among racial and ethnic minorities. I also will discuss barriers to colorectal cancer screening among racial and ethnic minorities, and I'll provide some examples of interventions that address racial and ethnic disparities in colorectal cancer screening. These are my disclosures. While the focus of my talk today is colorectal cancer, I want to give context of colorectal cancer in the spectrum of GI disease. And in gastroenterology, we pride ourselves for taking care of medical conditions that start at the mouth and end at the anus. And actually, disparities in GI disease also follow that spectrum. So even looking at esophageal conditions, especially esophageal cancers, all the way down to colorectal conditions, there are differences in health care and health outcomes by race and ethnicity. When we look at cancers that impact the human body, 18% of them are gastrointestinal cancers, which is a pretty big proportion given that we're just one field within medicine. And within GI cancers, 44% of them are colorectal cancers. We also, interestingly, or unfortunately, have two of the very few cancers of increasing incidence in the United States. There are very few cancers that are rising over time, and pancreatic and liver cancer are two of those. So really just emphasizing how important gastrointestinal cancers are in epidemiology and also health and wealth. This slide shows GI cancer mortality by race and ethnicity in the United States compared to whites. And it's represented as rate ratios where the line that's dashed is 1. And anything above that line of 1 represents higher risk of mortality compared to whites. So each panel is a different group: Hispanics, Black, Asians, and American Indians. And as you can see, many of the major GI malignancies, we have a disproportional impact of death in Hispanics, Blacks, Asian, and American Indians. Today, we're going to dive specifically in what those differences look like for colorectal cancer. I'll talk about colorectal cancer epidemiology and disparities, some of the contributors to these disparities. We'll dive into one of the big causes of these disparities, which is screening disparities. And then we'll talk about some of the interventions that we do in implementation science to direct these disparities in colorectal cancer screening. Colorectal cancer is common, and I think when I became a GI fellow, I was surprised that throughout my training in internal medicine, no one had really impressed on me how common colorectal cancer is. When we look at all causes of cancer in men and women in the United States, it's number 3. So in males, it follows just prostate and lung cancer. In females, it follows breast and lung cancer. When we look at mortality from cancers, it actually rises to the number 2 cause of cancer-related deaths in the United States. And that's because it's because it affects both genders, males and females. It actually arises above deaths from prostate or breast cancer, given that it impacts men and women. Since the 1990s, we've seen a decrease in overall mortality and incidence of colorectal cancer. And this is data from the SEER program that shows trends in colorectal cancer using National Cancer Registry data. And as you can see, whether you're looking at males or females, whether you're looking at incidence or mortality, over time, we have had overall improvements in the impact of colorectal cancer. When we break these data down by race and ethnicity, however, we see some interesting trends. And I'm going to go through a few slides that provide some of the breakdown by race and ethnicity. This particular talk focuses on many different racial and ethnic minority groups, and all of them have a different impact of colorectal cancer. So I think it's important to understand those differences. When we look specifically at incidence, you see that Black Americans are more likely to get a diagnosis of colorectal cancer over a lifetime. And in this image right here, we're looking at the rate of colorectal cancers in 100,000 people. The graph shows sexes combined, men and women, and the teal bars that are marked by the red arrows are African Americans. So African Americans have the highest rates in men and women and combined. They are followed actually by American Indians, which are the gray bar. And then after that, we have white Americans, Latino Americans, and Asian Americans with the lower incidence rates than the other groups. The mortality trends are similar in that African Americans are 40% more likely to die from colorectal cancer than white Americans, followed by American Indians, and then white Americans, Hispanics, and Latinos. Latinos and then Asian Americans at the end. Stage distribution is something that's very important as well. We know that when we diagnose colorectal cancer at stage 1, the likelihood of surviving 5 years is 90%. However, when we diagnose colorectal cancer at stage 4, the survival drops to about 11 to 15%. And because of that, we focus on the proportion of individuals that present with late stage disease. And in this infographic, you can see that the percent of cases that come in or that are diagnosed in distant spread is 25% for Black Americans, which is higher than the other racial and ethnic groups. And unfortunately, that predicts lower or poorer overall outcomes with morbidity and mortality for African Americans. Looking at trends over time, we actually have closed some of these gaps. And actually, when I was working on my dissertation, I focused specifically on the differences in Black-white disparities in colorectal cancer screening and outcomes over time in the United States. As you can see here in this graph, in the early 1990s, there was a big differential between white Americans and Black Americans. White Americans being represented by the blue line, Black Americans being represented by the black line. You saw a bigger spread as well between Asian Americans and Black Americans. Over time, we've had a step down in incidence in all of the groups, but a disproportionately higher step down in Black Americans. Now, at the end of time, so 2016 in this figure, Black Americans still have the higher incidence than white Americans. But the trend that we're seeing emerge is that American Indians over time are the one group that's increasing in incidence. When we look at mortality, it's a similar picture in that the mortality attributed to colorectal cancer in Black Americans is decreasing over time, and the gap between the ethnic groups is narrowing. However, again, you see that concerning rise in Native Americans. So again, to emphasize here that Black Americans have higher incidence and mortality, Native Americans are quickly following that. And then white Americans still have higher mortality and incidence than Hispanics and Asian Americans, although those groups, as we'll find out later, have larger challenges with achieving optimal screening rates. The other epidemiologic phenomena that we've noticed in the last several years is that there's been a change in the age-specific colorectal cancer incidence. So beginning in around the 1990s, we began to see that the trends in incidence varied by age group. Colorectal cancer historically has always been thought of as a disease of older individuals. So I remember being taught that, adenoma prevalence increases at age 50, and that's why we screen at 50. And really in people under 50, this disease is less of a concern. However, over time, since the 1990s, as you can see on the left graph, we've had an increase in colorectal cancer incidence in individuals who are aged 0 to 49. And this is the alarm that has sparked many of the changes in guidelines, starting with the ACS and the American Cancer Society in 2018, and most recently with the draft statement from the USPSTF about 2 or 3 weeks ago. What you see here, what I want to point out here about these graphs though, is though, this looks alarming when you see it going up in the 0 to 49s, 50 to 64, it's coming down. People who are over 65, there's a sharp decrease in colorectal cancer incidence, and which is great. However, you have to take note of these y-axes, right? So this y-axis is covering a much larger proportion of the population. And when we look at 0 to 49-year-olds, it's a smaller spectrum. So this uptick is important, and we don't want to put it to the side, but it's in no way compares to the rate of disease that we're seeing in individuals who are 50 and older. In fact, colorectal cancer, when you look at the distribution by age, about 11% of colon cancers are in individuals under the age of 50 right now, and about 18% of rectal cancers are in individuals under the age of 50. So still grand proportion of disease occurring in older, or middle-aged to older individuals. What about trends in early onset colorectal cancer, as we call it, again defined as colorectal cancer occurring in individuals under the age of 50? These trends are also alarming, specifically for our American Indian population. Interestingly, the white population has had a larger rate of rise of incidence than the Black population. So important studies by Caitlin Murphy and others have shown that when you look at incidence of early onset colorectal cancer, this Black-white difference here has actually narrowed quite much. Blacks still have the highest incidence of early onset colorectal cancer, but this rise in whites, particularly in rectal cancer in white males, is what's driving the overall trend and increase in early onset colorectal cancer. So rather than just point out these differences, our lab is interested in the causes of these disparities and also fixing them. And I think my greatest honor is working with the individuals that I work with to try to disentangle what is causing these differences and then moving towards implementation science to address this problem. There are many different factors that contribute to disparities, and those range from your employment and your social support or family income to your behavioral risk factors like tobacco use and your diet and alcohol use, all the way to quality care and utilization of healthcare services like colorectal cancer screening. We think of the root causes of disparities by race and ethnicity often as differences in social determinants of health. And I want to take a minute to break down what that is. There's been a lot of talk recently about social determinants of health since the COVID epidemic and our pandemic, and people understanding that there are things outside of your immediate health reality that impact your wellness in society. Now, I would say before June, no one really talked so much about social determinants of health. So these slides are not so interesting anymore, but we really think that these are the root causes and drivers of the differences that we see in health outcomes. I think of social determinants of health as the context in which we live our lives. So it's the analogy that I use is of a river, where there are upstream environments of that river that impact downstream health outcomes. So the upstream determinants of health are these macro social and structural influences on health and health systems. That includes things like governmental policy, social policy, and even the physical, economic, and environmental factor, reality in which you live in. And those things all have impact on your health. I often say to the medical students that we teach in our global health course that your health is often dictated by where you were born and the environment in which you were born. The midstream determinants are actually the result of these upstream factors, and they mediate the impact of the upstream determinants of health on downstream health outcomes. And those downstream health outcomes describe the health-related endpoints that result from the upstream and midstream factors. So that's things like heart disease, cancer, as we're talking about today, and even COVID-19, which obviously has been devastating for our global community this year. So let's give a specific example of how upstream factors impact downstream health outcomes. So for example, structural racism is an upstream factor that leads to health disparities. Structural racism is this concept that there are mutual reinforcing systems of discrimination and how things like housing, education, employment, earnings contribute to racial discrimination and eventually health outcomes. So in this example, you can see that the urban development or your living environment, again, where you were born, impact whether you live in a food desert, whether you're exposed to environmental toxins, whether you live in a space that's safe for you to go outside and exercise and be physically active. And those things result in your diet, whether you have high intake of processed foods, which we know is related to colorectal cancer risk, your activity level, and downstream from that, we have outcomes like chronic diseases, obesity, type 2 diabetes, and microbiome changes that we know all influence your colorectal cancer risk and your risk of dying from colorectal cancer. The result of these social determinant health is inequities across the clinical care continuum. And today we're going to talk mostly about prevention and early diagnosis through screening. However, you must realize that these disparities span the full spectrum from risk factors to disease, as we briefly touched on, to survivorship and clinical outcomes. So I think for many of us who work in this field and who have been doing this work for some time, we come to a point where we wonder, is it really race that we're measuring, or is it racism that we're measuring? Because technically, race is a social construct that is actually really a deviation of color. And when we're looking at all these differences that are a result of social determinants of health and things like housing and your work environment, is it actually discrimination and racism that's leading to these differences in health and health outcomes? And I challenge all of us to really try to think about health disparities and health equity with that frame. So talking specifically about colorectal cancer screening is important when talking about colorectal cancer outcomes. And that's because we know from Ann Zauber's group and others that the impact of colorectal cancer screening has been instrumental to us decreasing the impact of colorectal cancer on society. So this amazing study that Anne's group did is a modeling study, but they were able to show that the benefit of screening for colorectal cancer likely reduces the impact of colorectal cancer incidence in the United States by about 40%. So just by introducing screening programs in the United States, we've dropped our incidence of colorectal cancer by 40%. And that's why many of us who are in the field of disparities focus on screening as a mutable area where we can have impact in colorectal cancer outcomes. Nonetheless, in this country, we are not great at screening for colorectal cancer. And these are data from a study that we published, I guess it was last year now, that looked at disparities in colorectal cancer over time by race in the United States. The blue line represents the overall screening rate in the United States, which we think is about 66 to 68%. And each of these bars represents a different racial and ethnic group. And as you can see, Black Americans screening rate is about 66% compared to white Americans at 70%. And this gap has actually decreased over time. There was a period of time in the mid-1990s where it was much larger and Black Americans have caught up. Although when you look at certain populations, and we'll talk about FQHCs and federally qualified health centers, the gaps are much bigger. There are groups though that are still quite behind. And the reason why the discussion of ethnic and racial disparities in colorectal cancer is important to include other racial and ethnic groups is because look at what's happening with our Latino population, our Native American population, and our Asian population, whose screening rates are even below Black rates in many national surveys. Now, I want to give a shout out to New York City because you are one of the few places in the country that's actually engaged in a public health campaign to help reduce gaps in colorectal cancer screening by race and ethnicity. And this is a graph that shows the impact of work that was done by the New York Citywide Colorectal Cancer Control Coalition, which I think we refer to as C5, which I know some of your faculty and former trainees were involved with, and really shows that New York City was able to close the disparity gap in screening in African Americans by decreasing the inequalities in access to screening services. So you can see Blacks is represented by this blue line compared to whites. That has decreased over, this difference has decreased over time with implementation of this public health effort. And I think New York is celebrated because of these achievements, and many different states have started their own coalition. I know in California, we have C4, which I am part of, which is the California Colorectal Cancer Coalition, which is trying to do the same thing in our large metropolitan areas. There are still challenges in New York City, and this is a study that was done by Peter Liang, who's a dear friend of mine at NYU, that showed that even though some of the gaps in New York have changed, we still see persistent disparities in many groups. And it's important to recognize that these labels are somewhat arbitrary. And when we say Latino, it actually includes many different groups. And look at the differences that you see when you look at screening rates in Mexican Americans in New York City compared to Dominicans, for example. So again, emphasizing that this more granular work where we break down actual environmental and cultural factors is essential in addition to looking at the larger trends. In addition, Peter's group really does an excellent job of looking at the subgroups of Asian Americans. And this is another group in which we've got a lot of work to do, a whole nother presentation on colorectal cancer in Asian Americans. The other thing that we are up against is the United States Preventive Service Task Force recommendation, just fresh off the block in October of this year, now recommending that individuals in the United States who are average risk for colorectal cancer should likely begin screening at age 45 instead of 50. At this point, it's a draft recommendation. It won't be finalized for several months, but if finalized, overnight, there will be an additional 22 million Americans who are due for colorectal cancer screening. So as we are focused on these disparities and differences, and the disparities are racial, ethnic, our gender, also regional and geographic, which we haven't even got into that. There's also differences in urbanicity and rurality. we now are also going to be challenged with trying to add an entire different age group to the group of individuals that we outreach to and get in for screening. We'll see if this holds. I think it's very likely that it will, and it does have some implications for ethnic and racial disparities in colorectal cancer screening. So now we'll move on to the portion of the talk where we're moving closer to the solutions. And as I've alluded to, our group has individuals that are looking at the full spectrum of GI cancer disparities. And we have individuals that focus more on the epidemiology side, and that's actually where my base in public health was. I actually went into epidemiology before I went into med school. And then we have individuals that are focused more on the etiologies for disparities. And my focus now has really switched into the implementation science and the evidence-based solutions. So I'm honored actually today to spend the rest of the time talking about the implementation part of this problem. Where I work, we have a center, it's called the UCLA KAISER PERMANENTE Center for Health Equity. It's located at UCLA Health. And it's also, we also do work in the VA, and we also do work in federally qualified health centers. Our center, it sits at the crux of our medical school, our health center, and the School of Public Health. So it's actually a phenomenal environment to be in because my researchers span everything from public health sciences to clinicians, and we all have different inputs to these problems. I like to think of barriers to screening in the underserved as categorical. And we spend a lot of time talking about social determinants of health. It is those midstream and those downstream factors that we really can split up into patient, system, and provider level contributors to disparities. I know this is a busy slide, but I do want to highlight what some of these contributors are. This is a summary of information from many systematic reviews and some incredible studies that have been done over time to really try to break down what's happening at each of these levels contributing to these disparities. At the patient level, we know that part of the problem is lack of knowledge of screening recommendation. There are beliefs and cultural factors. Also, there's a problem with health literacy in some populations, specifically the Latino population and the Asian American population. We just don't message right sometimes. There's also fear. There's fear of the healthcare system. There's fear of the procedure, which is often colonoscopy that is recommended. There's also what we call cancer fatalism, or fear of a cancer diagnosis. And this is more common in ethnic racial communities, the idea that if I'm meant to die from colon cancer, I'm meant to die from colon cancer. And there's nothing that I really should be doing to intervene with that divine destination. The other thing that comes up quite often is mistrust, which I think, unfortunately, is our way of putting blame on the patient, because quite frankly, the mistrust is rightfully rooted in some atrocities that have been placed on African Americans and other racial ethnic groups in healthcare over time, back to the days of slavery. Nonetheless, we do need to do a better job of outreach to communities that just don't want to touch a health system. The provider level factors are real as well. And I think one of the big problems that we have in this field is that we focus so much on the patient level factors that we don't realize that we're part of the problem. We know there are studies that show that physicians just don't know what the screening guidelines are sometimes. Sometimes physicians just don't recommend screening, and that is more often in ethnic and racial minorities. One of the very first studies I did as a fellow actually showed that provider recommendation for screening is the #1 factor that predicts screening uptake. And African Americans are more likely than any group to report that their provider did not recommend screening. And that really just emphasizes the importance of the provider role. I lump together system and policy level factors because they're quite intertwined, and honestly, we have very little power at the policy level, most of us, I should say. However, these things include access to screening tests, colonoscopy capacity, whether your EHR includes reminder systems or other workflows to make it easy for primary care providers to order colonoscopy or other screening modalities. And then at the policy level, the ACA has been the major intervention, and we'll talk about that in a minute, and about how it's really limited financial barriers to screening, and to not yet to follow up, but that's actually the hope of some of the policy changes that we hope will come in the next few years. So what are the interventions that we try to do to address these different barriers? I also separate these the same way, and I'll briefly provide an overview of what we've done and what is evidence-based that can help decrease or reduce disparities. At the patient level, this is the majority of interventions. I actually last night was updating my slides and I quickly said, well, let me go on PubMed and see if there's anything new in this area. And I'm always shocked at how many patient interventions there are and how few provider interventions there are. But the patient interventions we see, we know that providing education, direct outreach, usually that's a telephone or mailed outreach, reminders to patients at the time of their appointment that they're due for screening or the time when they've reached screening eligibility age. Print media and video media are very popular, and the other that's coming into play right now is text messaging, and we actually use a lot of text messaging in our studies. And then the other interventions that are popular are incentives, which actually has some mixed data, and patient navigation. At the provider level, there's been direct outreach, and really the only studies out there are showing that if you assess providers and tell them that their screening rates are low, then they're reactive to that and maybe will pick up their screening recommendation. So we as providers always want to perform well, and that often is drivers to how we provide care for our patients. At the system and policy level, as I mentioned, reminder systems have been incorporated into EHRs, also changes in clinical workflow. A lot of health systems, including ours, have started a population health management division or department. And I work very closely with that team to try and do everything that we can to improve preventive service utilization amongst our patients. I want to provide a couple examples of interventions that we know have been effective. Patient navigation is a hot topic right now. And in this study, which is one large medical center, they did an RCT where one group of patients got a telephone delivered individualized education. They used bilingual navigators to call patients who were overdue for screening, about 800 of them, and to try to understand what was making it hard for them to get screened and address each of those individualized barriers. They looked at the outcome of colonoscopy completion within 6 months, and they saw a difference. They saw that in the navigation group, screening uptake at 6 months was 61% compared to 53% in the control group. Navigation is a hot topic right now. We talk about it in everything from screening to follow-up of abnormal screening. The biggest challenge to this, I think, is that it requires resources, and a lot of health systems just don't have these individuals to do the navigation for the patients. An example of a system level intervention is mailed fit outreach. And this is also a very hot topic right now. This is a study that was done by our colleagues at UCSF and Stanford. And Ma has done some really great work specifically in safety net systems. They used 8 clinics in a cluster randomized trial where one group of clinics got every patient who was due for screening got a mailed postcard saying, you need to be screened. They were called, and then they got a mailed fit kit in the mail. And then if they didn't complete the fit kit within a certain period of time, they actually called those patients again. And then the usual care group, it was just opportunistic screening, whether or not the primary care provider brought it up. And again, they saw a difference. So in the intervention group, almost 60% participated in screening. Usually it was mostly fit kit utilization in this study, compared to usual care, which is opportunistic screening, and only 37% of patients. At the policy level, as I mentioned, it's hard for us who are not in the White House to develop or to implement policy interventions. I think the best example of this is the Affordable Care Act, which provided healthcare for low-income individuals and also had provisions to cover grade A and B USPSTF preventive services, which includes now colorectal cancer screening. And in this study that we did, I guess it just came out this year, we were able to look at screening rates by race and ethnicity before the ACA and after the ACA. And then Samir Gupta and his phenomenal team took our data and were able to create this amazing graphic, which shows the remaining gap so that we get to 80% in every community, which, as we know, is a goal of the National Colorectal Roundtable and many of the big organizations that are focusing on colorectal cancer screening as a public health emergency. So as you can see, the introduction of the ACA, which is represented by this maroon color, actually had some impact in most racial ethnic minority groups. larger in some than others, but there remain these gaps. And I think, and especially in Los Angeles, we focus on this gap. We have a large and diverse Latino population, and they really have, we've really struggled with getting their screening rates up. So in our group here at the Center for Health Equity, we comb the literature for the best implementation strategies so that we can learn from the excellence of our colleagues and combine everything that they've done that's evidence-based in the field to come up with our own implementation strategies. And we have this incredible network of researchers here that can then work with community partners to help address colorectal cancer needs. We have decided that our best implementation strategies include multi-level, multi-component interventions. So what that means is that instead of developing interventions that just address patient or provider or system, we actually make sure that when we are working in an FQHC, our interventions have at least one component at every single one of those levels. We also believe in culturally tailored interventions. So we often will use what's in the literature and tailor it for the specific population that we are working with. We work in community settings. I'm sitting here in Westwood. I don't know how many of you have been to West Los Angeles. We don't see that many brown and Black patients at UCLA Health, at Ronald Reagan and Westwood. That's a nature of how LA County is constructed, and I'll show a map in a minute. So for me to do this work and to have impact, I need to leave this ivory tower and go into the community. And that's essential. I can have just so much impact if I work on Black and brown patients in our system. So a lot of these projects that I'm going to talk about are actually in FQHCs that are outside of UCLA and in actually north and east of Los Angeles. We also believe strongly that we need to engage patients and stakeholders in all of the research that we do. So this is LA County. We are the most populous and diverse county in the United States. We always like to say that if we could be a state, we'd be the 9th largest state by population. We also are a majority minority county, and we have the largest number of Asian immigrants, and we also have a large proportion of Latino Americans at 49%. The other population that's unique to us is that we have 45% foreign-born adults in parts of LA County. The FQHC, so federally qualified health centers are provided provisions by the US government under the ACA, as long as we continue to have the ACA, that they can provide primary care services to individuals who are low income, uninsured, or underinsured. And they provide care for about 22 million Americans in the United States. This is our federally qualified health center, our community health center landscape in Los Angeles. And right now I'm sitting here on the west side. As you can see, the majority of these are concentrated north and east of me because that is where these populations live. We have 49 FQHCs in just our county, which is, some states have 2 FQHCs in the entire state. And these FQHCs serve about 1.1 million people annually. So most of our projects are actually up here in the San Fernando Valley, and then I have some projects in South LA, which is specifically of African Americans. When you look at colorectal cancer screening rate and rates in federally qualified health centers, this is government data that shows that over time, we've done a better job at screening in FQHCs in 2019, though the screening rate was still less than 50%. And look at this, the large majority of FQHCs have screening rates that are lower than 40 to 70%. And this large group here, 39%, who have really low screening rates. So again, emphasizing the importance of going to where the biggest problems are to do this work. When we engage with the FQHC, we develop an advisory committee, which is much more them than us. We actually engage in ongoing clinic engagement. I have 2 team members that sit in the clinic for weeks at a time and just observe. And then we also perform key and format interviews with administrators and patients and providers at the clinic to inform our work. And through this pre-implementation work, we're able to come up with interventions that are addressing patient, provider, and system level barriers. what are those interventions? I provided some examples here, and these are some of the things that we're doing in the FQHCs that we work in. So at the patient level, we've noticed that patients get instructions for fit kits and they don't know how to do the fit kit appropriately. Why are we focusing on fit? Because the reality is that FQHCs are primary care settings and don't have official connectedness to advanced care services like colonoscopy. So they often are dependent on stool-based screening. So I would say the majority of the FQHCs that we work with, they are a fit first screening community, and that they prescribe fit over colonoscopy, unless of course it's a family history or high risk patient. We've also, as I mentioned a little bit earlier, been using a lot of text messaging reminders. This is the idea that we'll give a patient a fit kit in clinic and then send them a text message 2 days later and say, did you actually complete that fit kit? At the provider level, getting to the problems with lack of knowledge about screening guidelines, we've done training. Also piggybacking on what we know from the literature, we've provided feedback reports to providers to let them know what their individual screening rate is. And then the system level interventions, which I think actually are most impactful, involve a systematic way of identifying patients that are due for screening. And we don't just do this at the annual visit. We do this whether you're coming in for a cough or cold, an immunization, or your annual visit, so that we can make sure we capture as many patients. We have wordless standardized instructions. We make sure that their EHRs are set up in a way that they can document when a fit has been administered and returned. And we actually involve not just our physicians, but also our MAs and RNs into providing counseling about the importance of screening and how to complete fit. One example is the Northeast Valley Health Corporation. This is one of the largest FQHCs in our country. It has 18 centers in LA County, and these centers are all here, if you know this area, and provides about 200 or 300,000 healthcare visits a year. The population is 95% Black and Latino and 19% uninsured. And as I mentioned, their primary screening modality is FIT. And when we started working with them, actually this is more around 2017, their screening rate was 51% for colorectal cancer. So we currently have 2 grants to do work with this amazing clinic. And we've been able to, in the first grant, focus on reducing the screening disparities. So it was just about initiation of screening. And then in this more recent grant, we are working on the problem of colonoscopic follow-up after positive fit. And this is a passion of mine. Most of my talks are specifically on this problem. The reality that very often, especially in FQHCs, we will give a patient a fit kit, but not explain that it's a 2-step process, or focus on bringing them back to the health center when that fit is positive to make sure that they're getting their colonoscopy. So we have a slew of projects in most of our FQHCs, and over time now, in every FQHC we work in, we're working not only at the screening problem, but the follow-up after abnormal problem as well. Currently, our priorities have shifted somewhat. I wouldn't say our lab is shut down, but we did take a pretty big hit in March and April because all of our human studies stopped. And we had to transition a lot of our work to telephone interviews and Zoom focus groups. It's been very interesting. Our clinics are now back open in many of the FQHCs, but a lot of it is still telehealth. So in some of the clinics, we've actually transitioned to mailed fit. And before COVID, that was impossible because these clinics didn't have funding to do that. But we've been able to apply for many small grants, and we've got some incredible donors who've helped us provide screening through other mechanisms during COVID-19. So right now, our focus in this group, last year this time, I never would have imagined what we're doing now. And we're really trying to assess how COVID-19 has impacted the clinical processes and also the screening rates. As I mentioned, we're trying to establish safe and efficient processes for getting screened. It was interesting, we were giving patients fit kits, and in this particular clinic, a lot of the patients don't live in a place where you can put the fit kit in the mail because they have either a thin slit or they just don't feel comfortable putting it into their apartment mailbox. So a lot of the patients will walk the fit kit back in. But they didn't want to do that because it was COVID. And especially in the beginning, everyone was told not to leave their house. So we had to think about a safe way or safe drop box in some of the clinics for patients to walk their fit kits in. And then in some places, we were able to actually give them mailing to mail it back. We also realize that there are competing priorities. We can't ignore that the African American and Latino population is a population that's getting hit hardest by COVID-19. They are also our essential workers, so asking them to do colorectal cancer screening is challenging. And we now are trying to find specific messaging to impress on people that although COVID-19 is raging, cancer doesn't stop. And we still need to continue our screening for colorectal cancer and other cancers as we deal with the pandemic. And the other thing that we've included is diversifying screening modalities. Many of the FQHCs were already using FIT, so this wasn't new to them, but in my quality director role at UCLA, I've spent the last 6 months trying to convince primary care doctors that they don't have to depend on colonoscopy and that they can order FIT for our UCLA health patients. And just by incorporating that, we've actually been able to pick up the screening rate at UCLA Health, which plummeted in March and April. And then right now, we're also working with our FQHC partners to anticipate the new USPSTF screening guidelines, which is very overwhelming to them. Many of them are already functioning at a screening rate of 40%, and now we're going to add additional people that need to be screened. Beyond colorectal cancer screening and beyond FQHCs, right now there is a national focus on health equity and health disparities. And I think we do need to focus on COVID-19, but we also need to look beyond that. And this slide is really just a summary of things that I think are going to be essential for us to rightfully address health inequities in the United States. And the first step is collecting accurate data. When COVID started, we didn't even know that there were disparities by race and ethnicity because we had no race and ethnicity data. And we need to be better at doing that across health systems. We need more federal support for research in disparities and increased representation of underrepresented minorities in GI medicine and research. I am 2% of my colleagues, and that is, I think, a problem if we want to achieve success in addressing these problems. We need to push for equity and patient participation, not only in clinical trials, but in cohort studies to try to understand the roots of disparities and inequities. And as I mentioned, we really need to increase community academic partnerships. Again, I just don't think we're going to solve this problem by sitting in our ivory towers. And then lastly, we need to develop and disseminate interventions to address disparities in colorectal cancer screening, and beyond that, the full spectrum of disease into cancer care. So in summary, I hope I've impressed on you that colorectal cancer is common but largely preventable. Screening is effective and cost-effective but underused. We have disparities throughout the cancer care continuum for colorectal cancer. These start at prevention and early detection. We didn't even talk about high quality treatment and survivorship, which I've got a lab member who focuses specifically on disparities in treatment, which is also an issue. There are many barriers to screening, especially for the medically underserved. And addressing these disparities requires the dissemination of evidence-based, multi-level, multi-component interventions that are in the right diverse patient settings. I think I'm gonna stop there. I went a little longer than planned, but there is time for questions, I think. So I'm going to, but I can't see the chat. So are there questions? Thank you for listening.
Yeah, there's plenty of questions. Don't
Okay.
worry. Thank you so much for taking the time to talk about all that. That was incredibly comprehensive and so, I don't know, just enlightening and impactful. So I would thank you for mentioning, giving a good shout out to C5.
Yay.
And the Colorectal Cancer Roundtable. So thanks very much. And for mentioning the FQHCs, we have many in New York City also. And I've always been struck by the fact that the, screening rates in the early part of this decade were 30% when the rest of the country was 50, 60%. And now, we talk about 67%, we're aiming for 80% in every community. And the rate is still in the FQHCs, in the 40s, right?
Right.
And then you also give a shout out to Peter Liang and the work that's being done in New York City ongoing to look at those pockets of low screening. So, in New York City, African, Asian Americans and Mexicans, for example. So, all right, it's a long way of getting back to thank you for everything that you're doing. But when you talk about culturally tailored programs, so what do you think would work best in those communities in New York or the Hispanic community in Los Angeles? Is it all navigation? Is it targeted messaging? How do you pick out the right message? What do you think?
Thank you so much for, first of all, for having me and also for your comment. I think that focusing on these pockets where we have the lowest rates is going to be essential. We're not going to get to 80%, like you said, unless we do that. And the tailored messaging is critical. For Asian Americans, we've learned that physician concordance is actually really important, and language, depending on the part of the country you are in, can be an important factor as well, in addition to just the sentence structure and the messaging that come across in the print media, or however you're introducing the information. In the Hispanic community, there's less evidence that provider-patient concordance is important, but language is important. We know that in Los Angeles, many times when our Latino population that is non-English speaking sees a healthcare provider, they bring a family member to do all the translation. And we know that that translation is not always perfect. And we know that when that person gets home, they don't necessarily have that individual there to make sure that the screening kit gets done. So it's going to be important that we do things like the word list instructions, or that we use language that we know patients can get value from. And then in the Black community, surprisingly, there's been less research on the specific messaging for the Black community. And actually the National Colorectal Roundtable has just made a commitment, you're shaking your head because you know, to look at this next. But I think I found that with my Black patients, it's a lot of diffusing the misinformation. And I should probably at some point make a presentation just on these cultural topics that come up. I've had conversations on everything from your prostate is not your colon to if you have a colonoscopy, it doesn't make you a homosexual. So there's so much misinformation and miscommunication in the Black community that I think we just have to take by the horns and just attack, because we're not going to penetrate if we don't. I do a lot of talks in churches and other community settings, and I always start by using the word stool and anus over and over and over again so that it doesn't become uncomfortable. Because I think especially in the Black community, talking about things about like bowel movements and poop and manipulating your poop to do a fit kit are just very foreign, and Black people don't even want to talk about a family history of colon cancer. So there's just so much that we have to do to disillusion this disease.
Well, I wonder if I can ask a question. First of all, thank you so much. It seems like every other day I'm on a Zoom and Fola is speaking and teaching everybody. I don't know where you get the time or the energy.
At 5 a.m. in the morning.
At 5 a.m. Yeah, your day is 3 hours longer than ours. The thing that intrigues me is that, as more and more physicians want to practice anti-racism, we forget about accountability, or we haven't thought about accountability, and who are we really accountable to? We're basically accountable to our community, to our patients. And in East Harlem, 60% are Latinx and 25% are Black. And we, as academic institutions, we often do not engage the community in the deliberations. They're not at the table, helping us and guiding us and telling us what they need. As physicians, we are often in a position of telling people what they need because we're the doctors and we know better, but we don't listen. And we don't listen to communities telling us what they need and what are their priorities. In your FQHC work, you have an advisory committee. I'm curious, who composes that advisory committee? How do you identify members of the community? Is it faith-based? Is it people in business? Who functions as your advisory committee for your outreach work?
Thank you for that question. It's great to see you again. Our advisory committee, so in the Northeast Valley, we ask the clinic what they want the advisory committee to be. And I'm kind of surprised because it's a little bit different in some settings, but overwhelmingly they say that they want patients on that committee. So they generally will approach patients who they know have been part of their medical community for at least a couple of years. We have administrators that work in the clinics as well. We have lab staff, we have front desk staff. And then we have very few providers. So we make sure that at any of these advisory meetings, and we have 4 to 6 a year, we've had more this year because of COVID, we make sure that there are not too many white coats or researchers in the room. And we're very careful that when we are, I like to talk a lot, and I have to pretty much just press a mute button during these meetings because it's not about me talking, like you said. And they cringe. They tell us stories about researchers coming in and telling them what to do. And they say that that doesn't work, and that's why those research partnerships have not persisted. So we really focus on our team and coming in and listening and taking notes. And even when some of their ideas we know won't work, we really try to incorporate some of the concepts that they think are important. And patients being part of that is critical.
Thank you
Hi,
again. Go ahead.
Cindy, I just wanted to ask a question, about the uninsured. And so how are the uninsured covered? We still, I think, here have, and you discussed a little bit of a 2-tier system. So the insured are getting colonoscopies and the uninsured or the underinsured are getting fit. Just wonder if you could address that.
Thank you for that question. And I would say that differential is changing a bit in that there are many insured people now that are getting fit. FIT has increased. It's the #2 modality for colorectal cancer screening in the United States. And there are people in underinsured settings and safety net settings that are getting colonoscopy. And one of the small grants that we have at Northeast Valley is to make sure that when a patient demands or requests colonoscopy, that they have private GIs that they can go to. Now, finding the private GIs that will take that reimbursement is the challenge. So part of this is on us, right? And I'm actually giving a talk to the Southern California GI Society in 2 weeks and gonna make the plea that I need some of them to partner with us because we need to provide this service, especially for higher risk populations, African-American populations, and people with a family history. But yes, more or less what we're happening, and it's not just, I think, attributable to insurance, that's the patient preference in many cases. Overwhelmingly, in my experience, my minority patients are saying, I prefer to do the FIT unless you feel strongly that I need to do the colonoscopy. And I'll be honest with them when I think that they need to. So I think that's okay. I think that we're moving towards a community that is accepting of FIT, if it's done annually, if it's done correctly. And I'm going to say it again, if we make sure we follow up when it's positive. And I think that second step needs a lot more attention in implementation science. I hope that answers your question.
Well, let me ask a question. Pascal White.
Oh, is Pascal there? Oh, hi, how are you? I put some of your studies in.
Yeah, oh, there. Pascal. He has to do a colonoscopy, so she asked me to talk the question through, which is,
I see her, okay.
Congratulated you. But she wants to know, how do you propose increasing physician recommendations for screening? So do you do it at a trainee level, at a attending level, both? What do you do? We
are a hard group. So what we have been doing, and I haven't done this in the FQHCs so much because there are just so many things that we need to focus on. But at UCLA, we have a nudge work group. And this was started by our, I think is Brejan on? I thought I saw him. I'm kind of interested to talk to you about nudges and QI at some point. But this is part of one of our QI initiatives. We got a big grant to nudge providers. So we started incorporating, and it's not, I mean, no one likes getting those alerts that shut down your whole screen and you can't advance in the EHR till you deal with it. But we're trying to find nudges through the MAs, through the paper route that the provider sees when they see the patient. And even as the patient is going out the door, when they're checking out with the MA, a nudge at that level where the provider can retroactively at the end of the day when they're going through the notes, add a FIT test or add a colonoscopy. So yes, we need to do the upfront education and let providers know that they need to be better at recommending screening, but primary care doctors are overwhelmed in this country. It's a huge problem. I actually just wrote an op-ed on how we are failing at primary care and prevention in this country. And we need to help offload our colleagues in primary care. And to do that, I think we need to be more sophisticated in how we use our technology in EHRs.
Hey, Fola, it's great to see you. Thanks for a great talk. I'm happy
Hi.
to talk about that. There's some good work in geriatrics that can be leveraged as sort of proof of concept. I guess in the last second we have, I had one question, which was particularly at the UCLA campus. Have you been able to, has the institution allowed you to be able to bring patients into the discussion for the design of the intervention? So not just as advisory partners, but really getting a diverse group of patients that you serve from the community to help design what the intervention should look like to better engage people in completing screening?
We just started this. So at our CTSI, we now have a patient engagement committee. And when we write grants, and I'm writing a grant right now with one of our primary care colleagues, where we're actually going to be recruiting patients from that work group to be part of our implementation, our intervention design. So it's very new here. They've used it in palliative care, and they've used it. There's one other department that's already used this work group. My understanding is that it's a volunteer basis, but then you also can ask the existing members of the work group to recruit certain demographics for you as well. So we'll see how it works. I'm excited about it because I think especially institutes like PCORI, even ARC, they're really focusing on patient engagement at the design level. And we're not, again, Ivory Tower and the directiveness of physicians, we're just not used to incorporating our patients in these decisions.
Okay. Thank you so much again, Dr. May. That was a very enlightening, comprehensive overview of all the challenges, as well as giving us some very practical solutions for addressing them. So we just want to thank you again for taking the time to cross the continent and reach out to us and share all of the great work that you're doing.
Thank you,
Thank you
Fola.
Thank you so much for having me. I hope that New York continues to do well. It's such a scary time, but it's nice to connect even electronically. Everyone have a wonderful weekend, and thank you for having me.
Thanks so much.
Thank you.
Okay, bye.